Hello everyone. So I technically lied on the syllabus. If you would like to get 1 percentage point on your grade, please complete the course evaluation. You should have been emailed it or have access to it by now. If you send me a screenshot that you completed it, you don't have to send me what you said, but just send me a screenshot as proof that you completed it. I will add that onto your final grade at the end of class. So to get to what we're really talking about today, it is euthanasia and physician-assisted suicide. And this is relevant in New York because there's been a bill bouncing around that might enable some limited forms of euthanasia or physician-assisted suicide. So it's something that's in the news. And to kind of give you a reason why I like to have this at the end of the class, it's because the kinds of problems we didn't cover cloning, but surrogacy, enhancement, surrogacy again, they all have one thing in common is that they kind of hinge on this question of choice. And Velleman takes this problem of denying autonomous choice by default very seriously in the case of physician-assisted suicide. And a lot of times I've heard you guys talk about how something is paternalistic to not let someone do something. And Velleman is going to give a reason why paternalism is not going to be a good justification in some cases of limiting choice. So let's kind of get to it. This is Velleman. So Velleman assumes patients always do what in choosing? That is, that they do something that makes it harder for him to prove the point of his argument. So he's going to make sure that he's not making his argument rest on the fact that people are choosing wrongly. He's going to stipulate that people choosing death are actually, it's going to be in their best interest to actually commit suicide or physician-assisted suicide or be euthanized. He's going to grant that, so there's no cases where someone is going to regret having done the act itself. So everyone who's going to die in this argument is going to be dead because they wanted to be dead. So Velleman thinks that he's kind of pointing to a reason or a situation where having an option will make you worse off even if you choose the right outcome. And we'll get to that a bit, but first let's get some just ground definitions. So euthanasia, eu means good, and thanatos, death in Greek. So euthanasia is a good death by definition. So the death must be a benefit to count as euthanasia, and it must be intended as good for the patient. So it can't be the case that you accidentally kill someone and they actually were wanting to die, and it has to actually be intended to be good for the patient. So if you kill someone who does not seem like it would be good for them to die, you can't call it euthanasia or physician-assisted suicide. And doctors, not patients, perform euthanasia. So the kind of defining feature here is that euthanasia is performed by the MD, whereas physician-assisted suicide is kind of both, right? So patients are probably unwilling or unable, right? Because it's a pretty difficult decision. People are not easily prone to make this decision. It's a very difficult one. And people that aren't able to choose might believe, correctly or wrongly, that dying would be to their benefit. So conversely, physician-assisted suicide is going to involve the patient killing herself when the doctor assisting is kind of prescribing or providing instructions on how to end one's life. So euthanasia involves intending death, and with physician-assisted suicide, it doesn't necessarily have to be the case. It could just be that the doctor is providing the patient with the materials to do so, but is not wanting it to occur, even though he thinks he should provide the lethal pills or however they're assisting. So pretty important is the kind of types of euthanasia. So there's 6 different variations of euthanasia. So there's one of the main distinction is active versus passive, and just kind of get into them here. So active is going to be where um, the physician is actually assisting directly the death in question, and passive is going to be where the physician is not assisting, even though they probably could. There's also voluntary and non-voluntary, and involuntary. So these are, okay, so let's just walk through them really quickly. So we have active, just the physician doing the act. Passive, physician is just allowing the death to occur. So we could have voluntary or involuntary. So voluntary is going to be where the patient is fully aware of what they're doing and they want it to happen. Involuntary is going to be when the patient is not consenting. They don't want the euthanasia to proceed. And non-voluntary is going to be where the matter of consent is not applicable or not obtained. So this could either be not asking the patient, or it could be in the case of you can't really get consent from them, perhaps incapacitated person or someone too young to even understand what consent is. So these are all kind of like different transformations we could do, and you should probably pause the video right now and kind of walk through a couple of these. So there could be non-voluntary active and passive. There could be involuntary active and passive, etc., etc. So these are all different permutations that are different kinds of descriptive cases. So don't think that the taxonomy is going to tell you which one is good or bad. Obviously, non-voluntary and involuntary look a bit more suspicious ethically, but not necessarily. So the euthanasia taxonomy is not supposed to, tell you what's right or wrong here. So the only value judgment in the decision to commit euthanasia or physician-assisted suicide is the appraisal that euthanasia, not physician-assisted suicide, is that the death would be good for the patient. That's the only value judgment. The rest is just descriptive. So all these types could be impermissible, like really, or permissible. Don't, think that taxonomy is going to tell you anything here. Maybe a good thing to think about right now is which ones you think are particularly difficult or easy to defend philosophically and why. This might help you for your discussion posts later. So some doubts about the dignity-based right to die. So Velleman is against the institutional or the legal right to die, but not the moral right to die. So don't get this confused as well. This is another common mistake in this article, that the former would involve not only a legal permission to die, but an obligation of the medical doctor to provide it upon request. He believes that the moral case is pretty easy to prove and pretty simple. He doesn't think it follows that the institutional case is clearly the right way to go for euthanasia or PAS. And another relevant kind of reframing that Velleman does here is that he doesn't believe that the modern interpretation of autonomy, which is like willing to get around, willing to be, independent in this, not live in a nursing home, for instance, these kinds of autonomy are not really what we usually think of in terms of autonomy in philosophy. So he points out this big distinction, this big problem with the way that most people talk about dignity. They say most people defend dignity for physician-assisted suicide by saying that look, it's undignified to not be able to get around, to have your body degrade, have your muscles waste away, and not be able to be independent. Velleman notices this is like a kind of dignity, but it has nothing to do with the kind of Kantian dignity that most philosophers are worried about. Why? Well, the Kantian autonomy is grounded in rationality, and rationality seems to be a bit better of a foothold for some kind of philosophical normative view rather than just being able to walk around. The Kantian kind of autonomy is being something like being able to be recognized as a rational agent, as a end in itself, basically. So the two kinds of autonomy, I just kind of went over them here. So he kind of says to make the only decisions that others could join is not necessary to give them actual decisions to make, nor is it to give them the means to implement the decision. To say that kind of rational Kantian autonomy isn't compatible with the modern contemporary account of autonomy. So the problem with too many choices is a pretty novel, interesting contribution Velleman makes. So Velleman is claiming that having more choices can make you worse off, even if you choose rightly. Remember, we're stipulating that all the people are choosing rightly in this thought experiment. So he isn't defending paternalism by restricting their choice because they will choose unwisely or hurt themselves. So this is not obviously a case of paternalism. Maybe you disagree. If you can think of a couple objections to this, this would be an interesting angle to press. But he's not saying that we shouldn't do physician-assisted suicide and euthanasia because people will pick wrong. That's the main point here. And that's pretty interesting, right? You wouldn't imagine that you would think that you shouldn't have a policy if people never chose the wrong outcome that the policy is giving them. So, example of being harmed by too many choices. So if you're in a bargaining position of strength, sometimes you're less fortunate because you have more to give the other side. So that's an example. Another one is if you are a cashier and you have the option to open the safe. This could be bad, even if you always open the safe and choose the right option when you're being robbed. Not having the option to open the safe would be better because if you can't open the safe, plausibly the gunman will not initiate the robbery or go away after he sticks you up, right? Kind of a more funny one is that if I am giving a dinner invitation to someone and they don't want to come, might have been better if I just didn't invite them in the first place, because even if they pick the best option, which is to not be, socially shamed by everyone in presence of the invitation, they can still have the worst outcome, which is that they go to an awkward dinner party when they would prefer not to, but the offer is giving them a reason to say yes that they didn't have beforehand. And this is the problem in a nutshell. So if I wouldn't have offered the invitation, everyone would be in the best world. And in offering the choice to the person of coming to the dinner party, they don't want to come, but they also don't want the kind of social pressure of declining. This is why so many people say something like, oh, I have plans. So this is just another example of this too many choices problem. Likewise, if I offered help to a student, it might come off as strange because offering help seems to suggest the need for help. And that might not even be true, right? It might be me saying it to the best student in the class, and it might cause a bit of a doubt. So Velleman takes a stance on what the default or status quo choice in life is, and this is relevant for the article because he believes that euthanasia or physician-assisted suicide is giving the option of choosing death, and the default is typically just to go on living unless you're an existentialist. They believe that you have to choose to live every moment you're alive, but unless you're them, you probably think the default decision is just to keep on keeping on and live out your time. But the problem here is that physician-assisted suicide offers you the choice of not doing that, of becoming dead, right? So exactly this. So more choices can harm by the pressures they put on upon a person, and forcing that person to rationalize why they're choosing a certain way. Um, and also it forces them to rationalize why the status quo or the alternative is better in a certain case. So we'll get them to that in a second. Uh, so exactly that, the burden of justifying why you would like to continue living near the end of your life might be place a burden onto you that would make your existence unbearable. So imagine you were in a hospital bed and you've thought about suicide and you're crippled and you suddenly have the option to commit physician-assisted suicide. That is, adding a reason that you might want to die if you were on the fence, say, that you didn't have previously, that might convince you to go through with it. And he thinks that this is a reason to think that it's unjustified. So this kind of pressure is one of the reasons you can push on, for example, in your discussions. So this might not be obvious, but it's important to be viewed as a kind of rational person and a person who will respond to reasons. So if you are bedridden and one of your only ways to engage in the world is just communication with others, if suddenly you feel that you now have to communicate with others while you're continuing to live, it might be time to actually commit suicide, because if that's the only way you can engage with people and you have to rationalize, um, then that might plausibly degrade communications with others. And further, we have this perception that we don't want to be seen as unreasonable, which is why we have to rationalize why we're trying to continue living, and we're not taking the physician-assisted suicide option. And recall the default under where physician-assisted suicide is illegal. The default is just to keep on living, right? But when you have an additional choice, you have to rationalize your choice to others, and this might make you have one less reason to live that you didn't have before the legalization of physician-assisted suicide. So patients don't want to seem irrational, so they continue to justify why they're doing a certain thing, because it's pretty degrading to not be treated as rational. If you've ever had someone stop arguing with you because they don't think that you're engaging with them in a way that they respect, it's pretty degrading to be kind of treated as a child in this way. So we don't want that, and this is why we are now forced to justify why we are or are not doing physician-assisted suicide. So Velleman notes that we're not really sympathetic to lives of dependence and passivity, and people might think that life is undignified because we're unindependent. Remember, this kind of like independence and autonomy is not something that's most people thinking about in terms of philosophically holding up the medical ethics, holding up their medical ethics, right? This is like being able to walk around, being able to do daily tasks. This kind of autonomy is important. No one's denying that, but it's not this like thick sense of normative rationality. Further is the pressure from family. So if there's a right to die, this might force people to, well, science says it right here: choice equals pressure. So it might be the case that the family now feels like they have to justify why they don't want someone to commit suicide because they're bedridden, costing them a lot of money because they're paying for the hospital bills, let's say. Uh, then there becomes this kind of justification game where the uh, patient is going to try to justify why they might want to do the physician-assisted suicide as a gift for the family. So, and then it sort of seems that might be the case that if people judge your life not worth living, you seem selfish if you continue to not die. You might be blamed as a kind of moral coward, and this would have never came around if there was no right to die. So, kind of to sum up, this is how you can be harmed by having an additional choice you didn't before. So, recall this is one theme that's been coming up in the course with the various topics. So, just a kind of Gallup poll, 69% of people in 2016 think that euthanasia should be legal. But Velleman, however, doesn't really think that institutional side is such a strong case. So the article's called Against the Right to Die, remember? So he doubts the kind of legal and institutional guidelines could be written in a way that separate accidental deaths from those that aren't. So just because you're consenting to go through the procedure doesn't mean that if there was no law, you wouldn't have gone through with it. So he thinks that it's a bit too nuanced for a policy decision. So he's okay with experimentation, but mostly he thinks it's unjustified. So how will this new choice option be perceived by the patient and their loved ones? And how will it affect the relations? And will people be spurned for accepting or declining the option? And would he do it as a gift? And are they generally willing to accept that favor? So these are all kind of like empirical things that are going to really probably change the way that you think about the argument. So it's worth to think through if you think any of these are going to be more prevalent than others, or if some are not problematic or not. This might be a good itemization or a list that you can start picking at to find quibbles with his argument. So Velleman is kind of interesting in that he doesn't think that there should be a right to die, but he doesn't think that we should punish people who are physicians who go through with doing euthanasia or assisting people commit suicide. So he's for legally having it banned, but if it takes place, he's okay with it being kind of unpunished. So he thinks this is a way to leave the choice off the table for everyone. But if you really want it, you could talk to your doctor about it, for instance. And if it's the norm that it's illegal, but if you really do want to use the euthanasia or physician-assisted suicide, you could get it if you really wanted. Kind of like if you decriminalize drugs, they're still illegal. You're not supposed to have them, but the punishment is kind of alleviated in the case of just petty possession, right? One kind of problem with this is that patients want to trust doctors' judgments on this. So if it's up to the doctor, you're not going to have a right to die. And if you are 100% sure that you want to die, the doctor can say no. So this is one of the problems. Well, it's not a problem. Velleman knows this, but it's kind of trade-off. So you might worry that poor patients don't really have such a good relationship with doctors, and that because they have more of a transient relationship with doctors, that this might complicate the story and make physician-assisted suicide less likely for some parts of the society. And what I'll leave you with here is just kind of this question of which trade-off is better. So you have one where so those who want to die and should are legally allowed to do so. And through the result of legalization, some people who shouldn't choose death will have their demise brought about prematurely because of the aforementioned pressures. Remember, this is not because they're choosing wrongly. This is because they are accurately assessing the situation and choosing the right option. But it still is true that if there was no law ensuring the right to die, they wouldn't choose to die. Or is it better that those who want to die and should are legally prevented from doing so in order that those who really shouldn't choose death because their lives still have value are not pressured into premature deaths? So this one loosens the kind of right to die and has the trade-off that some people are prevented from dying. So it's in essence asking, is it worse to choose to end your life? And if the rules were different, you wouldn't have come to this conclusion. Or is it worse that you would like to die, are right in assessing that, but are unable to access that because there is no right? So figure out how this kind of what you choose kind of links up to Dworkin's argument, and this would be a great place to start thinking about for the discussion post. So